Okay, thanks very much indeed, Robin, for giving that background to the Trust and where the Trust feels we should be developing our transplantation services. The programme that we've put together today is intended to be an interactive programme. We've tried to make it so that there's very little or minimal amount of talking and lots of opportunity for feedback. So we're very, very keen that we don't just present a lot of data and a lot of numbers. We want to just produce topics and then ask you to comment and see what you feel about the direction that we're taking for some of these topics. Now, the background to transplantation we felt was perhaps something that would be of interest because we all get caught up with the advances and what we're doing next and the results and the analysis of the results. But sometimes to look back and reflect on what's happened and how we've got to where we are today is useful, and sometimes it also gives us an indication of where we've gone wrong and where we should do better. So I hope that you'll find this very brief historical overview of some interest, and again I hope that it will stimulate some discussion. The idea for this session is for us to use the historical background of what's been done and where it's gone right or wrong to then lead into Bimbi's talk, which is actually what we've actually achieved now and what we're doing in our current programme. And then that's going to lead into where we think the key areas are for development, where we should be doing better, where are our challenges, and we're hoping to address those challenges by some of our research programmes, and therefore we're going to discuss some of our research strategies. So we hope that that will sort of give a completeness, an overview of the problems and the direction of where we're going in the future. So I must say I'm not old enough to know all the historical developments, so I've brought my friend Barry Fuller along, who knows far more about the history of transplantation than myself. So when I get things wrong, I just expect him to stand up and correct me. So, historical viewpoint. I'm going to go a long way back, because although people say that transplantation is the great challenge of the 20th century, there's actually a lot of history before that. And as many of you know, I'm terribly biased. I'm Scottish, but I'm a Londoner now. And John Hunter is also a Scot that actually was preeminent in London. And therefore, I've mentioned him as being one of the key individuals. He was a phenomenal individual. He was a surgical scientist. And he made discoveries right across the area of human biology, human development, circulation, lymphatics, and really was a phenomenon also towards transplantation, because he made some key transplantation studies, and this is back in the 1750s, amazing achievement at that stage. So I'm going to run on really to the beginning of the 20th century and talk about how we got to being able to do transplantation at all, solid organ transplantation. And it's always said that we would never have transplanted an organ if we didn't know how to join together the tubes. Now, my disparaging hepatology colleagues may say, well, these transplant surgeons, they just have to join a few tubes together. Why is it so difficult? And it's actually true. You know, the basic concepts of transplantation are fundamentally very, very simple. But you do have to do these simple steps properly. And actually, the whole background of transplantation was the concept that you had to vascularize something. You had to allow the blood flow into the new organ. And if you didn't do that properly, if there was inhibition of your blood flow, then that organ would fail. And these individuals, Jaboulet in 1890s and Carrel around about 1900, described vascular techniques to allow these blood vessels to the transplanted organs to be joined together properly and not to impede flow. And these very, very simple things in transplantation actually allowed us to take forward what we've got in the present day. And as far as transplanting organs, kidney transplantation came a long way before liver transplantation. In some ways, liver transplanters are the new boys on the block. And renal transplantation, the history of it goes back to the 1930s. before Robin's time as well, where there was an attempt to do a renal transplant, a whole renal transplant from a 60-year-old donor into a 26-year-old recipient. This was done by a Soviet surgeon, and this is apparently a slide of the original procedure where it was implanted connecting onto the femoral vessels, the blood vessels to the leg. Doesn't seem to be a very practical solution to my mind, but I suspect that it was all that was possible in those days. The transplanted kidney apparently did work and produce some urine, but clearly not likely to be of any lasting benefit. And it was really in the 1950s that we actually saw the beginning of proper transplantation that was of clinical benefit, where a pair of twins were transplanted. Now, clearly the benefit of transplanting twins is that you don't have the immunological problems you have normally when you transplant an organ from one individual to another. And if you can avoid those immunological problems of rejection of the organ, you can have very good results. And that was what was done. There was twins that were transplanted with a live donor kidney in the 50s, and that was really the beginning of the successful clinical transplant programs. And that was carried out, or the first reported twin series was in Boston. But as I say, the problem with transplanting other individuals, so other than twins that had the same genetic makeup, was down to an understanding of immunology. And that really came into place round about the same time. There was lots of immunological research in the 40s and 50s, and Peter Medawar, whose picture's down there at the bottom, was considered the key individual, and he received a Nobel Prize for his work on transplantation immunology. And he was actually working at that stage here with us at UCL for that decade before he got his Nobel Prize. So he's considered as perhaps the leading figure of overcoming or improving our understanding of basic transplantation immunology that then led to clinical transplantation. As far as the liver is concerned, this is suggested that 1963 was not the year of the first successful liver transplant. I think that to say that it was successful was really a technical success, because in the early days the organ transplantation didn't really have anything like the long-term outcomes that we see today. But the start of the liver transplantation programs was in the early 60s, and this is Tom Starzl, who joined us actually here not so long ago for our 20-year get-together on the liver transplant side from the Royal Free Programme, and it was a great day to have him here, the man that had started off clinical liver transplantation. And this is a picture of him receiving the highest scientific merit in the US, which is the Medal of Science from George Bush in 2006. So around about the same time, it's actually interesting, there was a parallel with what was happening in the States with what was happening in the UK. And this chap here is Roy Cann in the centre here, who was working in Cambridge in the early 60s. And that there was a link between himself, a surgeon, and Roger Williams, who's the chap on the right there, who was working at King's. He's a hepatologist. And they established the Cambridge King's programme in the early 60s. And it was within a relatively short period of time that there was a huge expansion in the number of transplant programs. By 1970, you could see that there was 35 teams globally that were working on liver transplantation. And by that stage in America, there had been almost 60 patients transplanted and almost 30 here in the UK. But transplantation would have gone nowhere in the 60s if it hadn't been for the developments, basic developments of transplantation immunosuppression. And it's kind of interesting to see how all these things were coming together in parallel, the clinical developments, the technical challenges, and then the immunosuppressive drugs. And you can see that the first drugs that are still being used in transplantation were being developed there in the early 60s with azathioprine, the use of steroids for clinical transplantation, and then the discovery of cyclosporin, which was apparently discovered in 1969, but was in clinical practice within 7 years, which is absolutely phenomenal when you think about drug development times. To go from a basic discovery into clinical practice within a period of 6 or 7 years is absolutely phenomenal. So what happened in the 1970s once we had these immunosuppressive drugs? Well, although there was improvements, it was even by the end of the 70s there was nothing like the success rates in transplantation that we see today. It was suggested that there was a 30% success rate in transplantation, and the reason for that was that patients were being put through transplantation when they were too sick. They weren't strong enough for transplantation, and we've learned a very hard lesson that if you transplant patients that are sick, then they don't do well. There were also technical problems. The surgeons still had a lot to learn in the 70s, and there was still no satisfactory protocols for immunosuppression, and there was always this balance between over-immunosuppression and giving the patients risk of infection, and under-immunosuppression and getting rejection of the graft. But things proceeded, and by the early 80s it was then considered that transplantation had got beyond an experimental stage and should be rolled out to be of widespread clinical benefit. And you can see on this slide what actually happened, or maybe you won't, but down at the bottom is the years, different years between 1968 and 2010. And this is the number of patients that have been transplanted in Europe. And you can see down at the bottom here, 1983 is right down at this edge here, where across the whole of Europe there was 70 patients underwent liver transplantation in 1983. And you can see the phenomenal rise in the numbers in Europe. It seems to have plateaued perhaps in the last few years, and Bimbi's going to go on to discuss some of the reasons why that plateauing may have happened. But within Europe there's about 6,000 patients are transplanted per year at the current time. And it all really took off in the early 80s from the point of view of the number. But through the 80s and 90s there were other developments, and some new drugs came into the forefront that had fewer side effects than the initial immunosuppressive agents. Perhaps the two most useful ones were the introduction of FK506 tacrolimus, which was really an alternative to cyclosporin, and more recently sirolimus, which has some different side effect profiles and is of particular use in some patient groups. And then between the 80s and 2000, what were the major changes over that time? Well, we did see the concept of preservation solutions, and the major player there was UW solution, which was brought into clinical practice in the late 80s. That's the cocktail on the right side there is the components of UW, which really transformed transplantation, because up until that point it had been very much the case that the transplant organ would be removed and as quickly as possible it would be transplanted. But UW did allow a small window of opportunity to remove the organs at night and transplant during the day, and reduce the damage that was involved with that preservation period. And there was also an increased understanding of how to get the best outcomes from transplantation, not to select people that are not going to do well, better surgical techniques that I'll allude to, and better immunosuppression. From the point of view of the Royal Free, there was a transplant programme in the early 80s that Barry was involved with. It slightly predated myself, but that was led by Ken Hobbs, who's the first of the chaps at the top there. That programme was a small programme and then came to an end, and the whole transplant concept was then reinvigorated when Keith Rolls, who's at the top there, who was my mentor in transplantation, came from Cambridge. He had worked with Roy Kahn. And it wasn't long after the programme commenced that I started here and trained up with Keith Rolfe in transplantation. Our programme's a big, ambitious programme. We've got excellent results. It's audited very, very carefully, so we know that we do extremely well, and we're compared with other UK and international centres. And we do have a big and thriving research programme, which is one of the aspects that we want to discuss with you today. So where are we with the challenges now? This is just a lead into where Bimby's going, and really he's going to discuss. But we're clearly in a situation in liver transplantation that we have more indications than we have organ donors, so there's more people that require transplantation than we have donor organs. We have a problem with our ability to preserve these organs as well as we would like, and we're increasingly being pushed towards using organs because of the shortage of organs that are not 100%. And therefore we need some new strategies to try and improve the preservation of these organs so that they're transplanted in as good a condition as possible. On the technical side, there have been some modifications to technique that are of considerable benefit, but to a very small percentage of patients. We can split livers and use one donor organ and transplant into 2 patients. And that was originally described by Henri Bismuth, who's a Paris liver surgeon, and really a phenomenal influence in my career period. He described the first techniques in the late 80s, and usually the big right lobe of the liver would be given to an adult, and the small left lobe of the liver would be transplanted into a child. Although you can transplant a slightly extended portion of the left side of the liver into a small adult. And then we've got the history of live donor transplantation, where you would donate usually to one of your family members. It started off very much as a strategy to sort out the problem of the shortage of small organs for children. Usually a parent would give the small left side of the liver to a child, but it was then extended at the late 90s into transplanting adults, where you would have to give the large right side of your liver to an adult, and you would have your small left side of the liver, which would then regenerate and recover. And Tanaka in Kyoto was the person who is deemed to have transplanted the first adult-to-adult living donor. And although it's not really taken off much in the UK because of the risks of donation, this is the key to transplantation successes in some other parts of the world that don't have brain-dead donors. And this is what would happen to the recipient of that right lobe of the liver, the adult recipient. Their liver has been removed. You can see the implantation of the right lobe graft, and that right lobe graft will regenerate and grow and be a fully functioning liver as long as the perioperative management is optimal. And I'm going to leave you with perhaps the most controversial aspect of transplantation at the moment, and that's the use of non-heart-beating liver donors. Now, because of the shortage of good donor organs, we are being pushed very much to using and extending our criteria, and one of the categories is to use organs from people where their life support is withdrawn. Now, there's a lot of people who do have withdrawal of life support who have viable organs, but the whole technique of withdrawal allows a period of damage to those organs, and therefore they don't function as well as those from a brainstem dead donor. And really one of the crucial issues we have in clinical transplantation is how to optimise the use of these organs and how to prevent all the complications that are associated with this group of patients. And many of our research strategies is directed towards how to optimise organs from this group of patients. So in conclusion, that's been a very quick overview, which I hope you'll find of some interest, and perhaps as a backdrop to some of the issues that we're going to be discussing over the course of the day. I think that it has been a century of amazing development, from the concept of just how to join blood vessels together to the question of very standard and complex routine clinical practice. The majority of these developments really have been within our lifetime or within the last 30 years. And although our current results are excellent, there are some very major challenges that we need to face for some of our patient groups. And I think that we are in a perfect position from the point of view of our transplant programme and the support from the Trust and the university to resolve both the clinical and research problems that will be with us in the future. Thank you very much.